Very good day, very good evening to everybody. I would like to thank CPD Medical Education Committee of General Practitioner College of Sri Lanka to giving this opportunity to arrange the continuous medical education program under the, and at the same time, I would like to congratulate the newly appointed President and the Council of the General Practitioners of College of General Practitioners of Sri Lanka. And today, this evening, you all are welcome to update on chronic coronary syndrome. I would like to introduce the speaker today. She is Sandamali Premaratne, consultant cardiologist, National Hospital Bowl. And I will say something about her. She graduated from Faculty of Medicine, University of Colombo, 2004. And she completed the MD program at the University of Colombo, PGM, and trained at the Royal Bournemouth Hospital, United Kingdom. And she appointed as consultant interventional cardiologist at Teaching Hospital Jaffna in 2016. And she had started her serving as consultant cardiologist from Jaffna to Goal now. In between, she has served in Polonnaruwa District General Hospital and District General Hospital Negombo, and the previous appointment was at Teaching Hospital Kurunegala. And I want to mention that she is the Joint Secretary of the College of Cardiologists of Sri Lanka at the moment. And with this busy schedule, I greatly appreciate and warmly welcome you, madam, to this topic. Thank you very much.
Thank you, Desh. Can you hear me?
Yes.
Hello? Yeah, okay. Thank you, Desh. And first of all, I must thank the College of General Practitioners for giving me this opportunity to give this talk. And today, good evening, ladies and gentlemen. Today, my topic is update on chronic coronary syndrome. I do not have any conflicts of interest, and I must say that I base my presentation on 2024 ESC guidelines on chronic coronary syndromes. Okay, let's get on with this. First of all, chronic coronary syndrome is one of the commonest presentation in our day-to-day general practice. Let me take you through a few presentations or few cases that commonly come to us before I start with the presentation. My first patient is his 56-year-old male who presented with retrosternal chest pain of 3 months duration. With this chest pain is episodic in nature and it is tightening. Usually each episode lasts for about 5 minutes. There was no radiation of the pain, and it was not associated with sweating, nausea or dizziness, no autonomic symptoms. He noticed that pain appears when he was walking, especially after meals, and as soon as he stops walking, the pain relieves. He is currently on treatment for diabetes and hypertension. This is one presentation that we commonly get, and this is the second presentation. This 44-year-old lady, she underwent actually a medical checkup prior to getting on life insurance, And during this medical checkup, ECG showed significant T-inversions in inferior leads L2, L3, and AVF. She doesn't have any other coronary risk factors like diabetes, hypertension, hyperlipidemia, and no family history of ischemic heart disease, and she is completely asymptomatic. This again, in current context, is a common presentation to us. Not only in the cardiology practice, even in general practice, you get patients like this. And the third case scenario that I would like to highlight is about a 63-year-old female who has shortness of breath on exertion, which has been going on for last 2 months. She does not have features suggestive of orthopnea or paroxysmal nocturnal dyspnea, nor ankle swelling or generalized edema. She is currently on treatment for hypertension. So these could be the common clinical scenario that you can get during chronic coronary syndrome. So how are we going to approach this condition? Let me first explain what is chronic coronary syndrome. It is actually, as I described previously also, it's a range of clinical presentations or syndromes that occur due to alterations in the coronary arteries, not only the large epicardial coronary arteries, but also in microcirculation of the coronary vasculature, which could be either structural or functional, which can lead to mismatch between myocardial demand and blood supply, it is usually transient and reversible. And this myocardial mismatch between demand and blood supply results in hypoperfusion of the myocardium, which leads to ischemia, and it is usually provoked by exertion, emotion, or other stressful situations. And it can present with typical angina, or could be present as other chest discomforts, could present as dyspnea or shortness of breath, or can be asymptomatic. Usually chronic coronary syndromes are stable for long periods, but it can get progressive and can destabilize at any moment with leading to acute coronary syndrome. So briefly describe about the pathophysiology. I'm going to describe only the basic concepts. Previously, we consider only the fixed focal flow-limiting atherosclerotic stenosis as the pathology behind chronic coronary syndrome. Usually, these stenosis occur in large or medium coronary arteries. But currently, the thinking pattern has changed. Now we consider not only the structural changes like this, but also functional abnormalities, not only in micro or the large vessels of the coronary arteries, but also microcirculation. Changes in the microcirculation is also considered. And these changes leads to transient myocardial ischemia. At the macrovascular level or the large or medium-sized coronary artery level, so as I described, not only the fixed flow-limiting stenosis, but apart from this focal stenosis, diffuse atherosclerotic lesions can also lead to chronic coronary syndrome or ischemia, and can, without any identifiable significant luminal narrowing, they again can lead to ischemia. Apart from the focal atherosclerotic plaque disease or the diffuse plaque disease, other structural abnormalities like myocardial bridging. Bridging is where part of the coronary artery goes through the myocardium, and during the myocardial contraction, the vessel gets contracted, leading to transient ischemia, or the congenital arterial anomalies, and sometimes coronary spasm, vasospasm, can be responsible for chronic coronary syndromes or transient ischemia. At the microvascular level, it is commonly known as coronary microvascular dysfunction. Again, functional and structural abnormalities can cause angina or ischemia. There are two kinds of presentation in microvascular dysfunction. One is called ANOCA, the other one is INOCA. ANOCA is angina with non-obstructive coronary arteries, which present in chronic coronary syndrome states. During acute coronary syndrome, without significant obstructive lesions, patients can present with acute coronary syndrome, and that condition is called ischemia with non-obstructive coronary arteries, again due to microvascular dysfunction. Apart from these coronary conditions, Systemic or extracoronary conditions again can present like chronic coronary syndrome. For example, anemia in condition leading to tachycardia, myocardial hypertrophy, and fibrosis can lead to ischemia and can present like chronic coronary syndrome, and also can complicate the chronic coronary pathophysiology of myocardial ischemia or chronic coronary syndrome. This is just a schematic representation of this pathophysiology. It could be changes in epicardial and microvascular. Both structural and functional changes are considered, like I described before. So the atherosclerosis, intraluminal obstructions like hematoma, myocardial bridging, and coronary aneurysm. So other structural changes can cause ischemia. Same way, epicardial vasospasm can lead to chronic coronary syndrome. In microvascular disease also, structural and functional changes can lead to chronic coronary syndrome. So how do they present? In the recent guidelines, they have identified 5 categories of presentations. First one is the symptomatic patients with reproducible stress-induced angina or ischemia with obstructed epicardial coronary artery disease. Second category is the one due to microvascular dysfunction. The patient presents with angina, but there is no obvious stenosis of the epicardial vessels, but there are epicardial vasomotor abnormalities of functional or structural microvascular dysfunctions leading to angina. Third category is patients who had acute coronary syndrome or revascularization, and post-ACS or post-revascularization patient is the third category of chronic coronary syndrome. The fourth one is non-acute patient with due to chronic heart failure of ischemic origin, and the last category is asymptomatic individuals with coronary artery disease detected during cardiovascular risk assessment. Again, this is a diagrammatic representation of these 5 categories of clinical spectrum. So next is to describe how to diagnose and manage these patients with chronic coronary syndrome. And there are 4 steps in this process. Step 1, 2, 3, and 4. We'll go one by one individually. First step is to do the initial evaluation, and second step involves further evaluation. Third one, confirm the diagnosis and estimate the further event risk. And fourth step is the treatment. So the initial evaluation, this is where history and examination comes into play, and you need to assess them properly and to do basic investigations, resting ECG, biochemical test, and if required, lung function test and X-ray. If you find these after this assessment, if the patient's presentation is actually due to a non-cardiac reason, then you need to treat that underlying cause and no further testing is required. But at this stage, if you detect unstable symptoms or worsening symptoms of angina, heart failure, or arrhythmia, then you need to consider acute coronary syndromes or need acute treatment. Then patient should be admitted to the emergency department. So in the initial evaluation, the general clinical history and examination, we used to know that typical angina symptoms usually classified traditionally as typical, atypical, or non-cardiac or non-angina symptoms. The usual teaching is typical angina consists of 3 characteristics. It should have retrosternal typical chest discomfort and should be provoked by exertion or stressful situations. It should be relieved by GTN or rest. If all 3 are present, then it is highly suggestive of ischemia, or it becomes typical angina. But unfortunately, all these features don't present in all the patients, especially in patients with microvascular dysfunction and vasospasm. So it is important to thoroughly evaluate each patient who presents with chest pain before we classify it as a non-cardiac chest pain. Again, please remember, if these symptoms are recent onset and it is worsening in frequency or intensity, you should suspect a presentation of acute coronary syndrome due to destabilization of plaque disease. And in examination, need to do proper physical examination, including blood pressure measurement, BMI calculation, and need to look for anemia, valvular heart signs of valvular heart disease, left ventricular hypertrophy or arrhythmias. And need to look for other non-coronary vascular disease, look for peripheral vascular disease, palpate all the peripheral pulses, and auscultate carotid and femoral for bruise to look for any peripheral vascular disease. And need to look for other comorbid conditions like thyroid disease, renal disease or diabetes. And this is the table showing describing the clinical features, telling us how to analyze them, what are the features that will suggest this is more angina symptoms or chronic coronary presentation of chronic coronary syndrome, and what are the features that will make the presentation less likely to be chronic coronary syndrome. This is for the chest discomfort, and this is for the shortness of breath. So basic tests that we need to do are, after doing history and examination, need to do baseline ECG and standard lab test, especially to look for anemia and thyroid disease, and need to look for cardiovascular risk factor assessment, risk factor status, need to do fasting blood sugars and lipid profile, and other lab investigations that will help us to assess the prognosis of the disease, especially chronic kidney disease. And certain patients, we might have to do chest x-rays and pulmonary function test if the main symptom is shortness of breath on exertion. Right, then we go into the step 2, which involves further evaluation. And here we need to see whether, needs to assess the clinical likelihood of patient having obstructive coronary artery disease. And there are various calculations or scoring methods to assess this likelihood. But in ESC guideline, there is a risk factor weighted clinical assessment scoring used. I will describe that later. And here, with the assessment of clinical likelihood, the echocardiography and exercise ECG will help at this stage. And after assessment, if the clinical likelihood of coronary artery disease is very low, then you can actually stop going for further testing. But if it is low, moderate, or especially if moderate or high, then you need to proceed further with further testing. Say if the patient has severe comorbidities and very poor prognosis with low quality of life, then again at this stage you don't have to do further testing, but potentially treat for coronary artery disease and treat the patient with medical management without any invasive procedures. So how are we going to assess the pre-test clinical likelihood of obstructive coronary artery disease? How likely this patient is to be having coronary artery disease? So diagnosis, as I described previously, the patient's chronic coronary syndrome diagnosis is based on interpreting the individual symptoms, history and examination, and need to balance the impact of age, sex, risk factors and comorbidities, and then how to choose the best or the most appropriate diagnostic test to confirm the clinically suspected diagnosis. For this process, it is useful to have this risk factor weighted clinical likelihood model, and it considers sex, age, angina symptoms and number of risk factors in calculation. I hope you can see this diagram. Here I will describe it, so because it's sort of important. First step is to assess the symptoms. You are the patient is given scoring for these symptoms. If it is chest pain, if it is all three typical symptoms are present, you get 3 points. Each one gets 1 point. And if it is dyspnea on exertion with the following characteristics, then you get a patient gets 2 points. Afterwards, you need to calculate the number of risk factors present: family history, smoking, hyperlipidemia, hypertension, and diabetes. And then you need to estimate the likelihood. depending on the symptom score, sex, men, women, and then number of risk factors, and according to the age, you get the clinical high likelihood calculated in this diagram. And if it can be less than 5% means very low, and then 5 to 15% low, above 15%, up to 50% moderate likelihood. So this, once we calculated this pre-test clinical likelihood, depending on the additional clinical data, we can adjust the estimated risk. For example, if there are presence of peripheral vascular disease, or the adverse or the changes in adverse changes in the ECG, like Q waves or any arrhythmias, or if there are any changes in resting echocardiogram, or if we do any, if we have done many imaging tests previously, which shows coronary calcifications, that will modify our clinical likelihood. For example, if the patient has moderate clinical likelihood, if one of these signs are present, then the patient goes into the high risk category. Likewise, the risk estimation can be modified according to these clinical other clinical characteristics. Same way, the exercise ECG and cardiac CT can be used to modify the clinical likelihood. For example, if a patient has a low likelihood of clinical likelihood of coronary artery disease, if the exercise ECG test is negative, then we can consider the patient has very low likelihood of coronary artery disease. So as I mentioned, if there's very low likelihood, you can actually differ from doing further diagnostic tests unless patient's symptoms patient's symptoms persist. If the likelihood is low, then you can consider diagnostic testing, but the benefit is not very certain. But if the symptoms are limiting the patient's performance, then you can consider further diagnostic testing. The patients had moderate or high or very high clinical likelihood of obstructive coronary artery disease, then need further diagnostic testing. At this stage, we have to do the transthoracic echo, and also, so the echo will show us reduced, will give us an assessment of LV systolic function. If it is reduced, then we have to think about coronary artery disease. And presence of regional wall motion abnormalities will suggest the diagnosis of chronic coronary syndrome. And again, presence of diastolic dysfunction will help in the diagnosis of CCS. And again, not only making the diagnosis, to look for other conditions that can mimic chronic coronary syndrome, the transthoracic echocardiogram will be helpful. For example, to detect pericarditis and diagnosis significant valvular heart disease and cardiomyopathies can be diagnosed with using transthoracic echocardiogram. So it will be really helpful at this stage. And if the echocardiogram is not very conclusive, and it will not give any adequate information, then if the facilities are available, you can consider cardiac MR also at this initial stage, if it is available. And it will give us information again about the global function of the heart, and if there are any regional wall motion abnormalities that can be detected in CMR. And if there are a myocardial scar due to ischemia, can be easily detected with the myocardial CMR. And if CMR is performed with stress CMR, then that will be diagnostic of coronary artery disease. And apart from echocardiogram, exercise ECG also will be helpful, but unfortunately it has very low sensitivity and specificity, so the diagnostic yield is poor in exercise ECG. But it is useful in risk stratification. But in our setting, where we have very limited access to the sophisticated investigations, exercise ECG is a useful tool tool for the diagnosis of obstructive coronary artery disease, and it's especially useful in risk stratification and prognostication. Again, I'm not sure whether you can see here, then after assessing the clinical likelihood of obstructive coronary artery disease, and depending on these echo, ECG, and CT findings, the patient risk estimation or the likelihood estimation can be modified. This is what is highlighted in this slide. So then we go into the step 3, which involves the confirming the diagnosis and estimating the future event risk. The further test, doing non-invasive test depends on the again on the clinical likelihood and availability of this resources, local expertise, and of course patient characteristics and preferences. The preference is also taken into consideration. If patient has very high clinical likelihood of obstructive coronary artery disease, you can straight away go into invasive coronary angiogram. And also if there is suspicion of high risk obstructive coronary disease, that can lead to high risk of future event risk. And if there is evidence of severe myocardial ischemia, coronary angiogram is indicated. If there is only moderate or high clinical likelihood of obstructive coronary artery disease, you can go for either functional imaging that will give evidence regarding myocardial ischemia, or if it is only low or moderate probability or clinical likelihood of coronary artery disease, you can go for non-invasive imaging tests like cardiac CT angiogram. So this again summarize what I have been described so far. So if it is very high likelihood of obstructive coronary artery disease, you can straight away go for invasive coronary angiogram. If it is very low, you can defer further testing. If it is low, as I told, we can adjust or modify the estimated likelihood by doing baseline ECG, exercise ECG, echo exercise ECG or CTA. And if there are changes, then patient falls into the moderate category. And here, if there is moderate category, you can either do imaging test or functional imaging test. Or if it is high category, you can straight away go for functional imaging test. And if it shows severe burden of ischemia or very high risk features, then should go for invasive coronary angiogram. So this is a stepwise approach of the investigations of chronic coronary syndrome. So as I told you, confirming the diagnosis, there are functional and anatomical imaging methods. The non-invasive anatomical imaging method is coronary CT angiography. It is non-invasive and it has the same proven diagnostic performance as invasive coronary angiogram. And nowadays it's not only anatomical assessment that provides a CT coronary angiogram. It can give information regarding function also. There is this measurement called CT-derived functional flow reserve measurements that can actually complement the structural anatomical defect that is detected in CT angiogram. And the functional imaging tests that can be used, commonly available one is stress echocardiogram. And then we do have stress cardiac MRI in our country. Even though we don't perform commonly the SPECT and PET scanning, those are also available. They are again functional imaging tests where we can stress the heart with either exercise or pharmacological stressors and image the heart to see, look for any perfusion defects that will make the diagnosis of the coronary artery disease. The ultimate diagnosis of confirmation, which is invasive, is the coronary angiogram. Again, coronary angiogram itself will not only give information regarding structural abnormalities like coronary stenosis, it again will give information regarding functional assessment as well. There are methods to assess the functional significance of each narrowing in the coronary vessel. After making the diagnosis, we need to assess the risk of future adverse event, because chronic coronary syndrome can be complicated by cardiovascular deaths, ischemic events or hemorrhagic events, heart failure and arrhythmic events. So to assess these event risks, we need to have basic clinical details like age. With advanced age, the risk is higher. Any ECG changes, especially if there are any arrhythmias or baseline changes suggestive of previous MI, will indicate higher event risk. And angina threshold, if the patient has angina even with mild exertion, that gives information regarding high future event risk. And the presence of diabetes, chronic kidney disease, and reduced LV systolic function will make the patient's prognosis poor with regards to future cardiovascular acute events. And there are other methods, apart from clinical data, there are other methods to assess adverse risk, adverse event risk. We can use the stress test for that. Commonly used one is the exercise ECG. If the Duke treadmill score is falls into high risk category, then patients has high risk of future adverse events. And other stress imaging techniques like SPECT, PET, or stress echocardiogram, stress MRI will give information regarding the future adverse event risk. Again, even though coronary CT angiogram is not a stress test, but presence of significant coronary artery disease involving left main and 3-vessel disease will indicate the event risk is high. So if there is high risk, possibility of high risk of adverse events, even if the patient is asymptomatic, you can consider invasive coronary angiogram for further management. So then we come into the final stage, which is the treatment step. We have 4 arms here: lifestyle and risk factor modification, and disease modifying medical treatment to improve the prognosis, and anti-anginal medical treatment to improve the symptoms, and revascularization. Revascularization is indicated either by PCI or open heart surgery, CABG, to reduce symptoms or to improve prognosis in patients who are at high risk of having future adverse events, like I described earlier. So, medical treatment involves guideline-directed therapy. Need to reduce the cardiovascular risk like diabetes, hypertension, hyperlipidemia should be corrected, and smoking should be stopped. And there are lifestyle changes and exercise interventions that are described. I'm not going to go into details of these things because I believe it is a separate lecture. And there are anti-anginal, anti-ischemic medications for symptom improvement, and medical therapy to prevent future event occurrence, and then revascularization. So the anti-anginal or anti-ischemic drugs to improve symptoms, we have first-line and second-line drugs. The first-line drugs to start are either beta blockers or calcium channel blockers. If they are not contraindicated, like if the blood pressure is normal and if the heart rate is satisfactory, you can start beta blockers or calcium channel blockers straight away. And you can combine with second-line drugs if patient is not responding to first-line drugs. The options available are long-acting nitrates, nicorandil, ranolazine, ivermectin, and trimetazidine. And there are combinations that we can use for all of these options. You see that in green lines shows the use good combinations. For example, you can combine beta blockers with nitrates and nitrates with diltiazem. Likewise, you can combine the medications to improve the symptoms. If we suspect vasospastic angina, better to go for the options like nitrates, nicorandil, and calcium channel blockers. and there are trimetazidine and ranolazine are good for microvascular chronic coronary syndrome due to microvascular dysfunctions. So those facts also important in the management of chronic coronary syndrome. To prevent getting future events apart from revascularization, you need to be on a patient should be on a long-term medication. For that, we have antithrombotic medications, lipid-lowering drugs, and ACE inhibitors or AR blockers, and anti-inflammatory and metabolic acting agents. So the most important component is the antiplatelet drugs. We have the options of COX inhibitors, COX-1 inhibitors, aspirin, or P2Y12 receptor inhibitors, clopidogrel, prasugrel, or ticagrelor. Usually in chronic coronary syndrome, we use monotherapy. It's either aspirin or P2Y12 inhibitor monotherapy. Usually aspirin low dose, 75 to 100 milligram once daily. Lipid-lowering drugs are also an important category of drugs that are used to prevent future events. You need to have an LDL cholesterol goal of less than 55 milligrams per deciliter, or at least more than 50% reduction in baseline LDL level. You need to have the high intensity statin dose to the highest tolerated dose. If the goal is not achieved, or that is LDL cholesterol level of 55 is not achieved with the statin dose, or if the high intensity statin dose is not tolerated by the patient, then you can combine the tolerated maximum dose of statin with ezetimibe to achieve this LDL cholesterol goal. And ACE inhibitors and ARBs are actually indicated in chronic coronary syndrome if a patient has coexisting hypertension and ejection fraction is less than 40%, diabetes or CKD. Okay, thank you so much. I have come to the end of my presentation. I try to keep that as simple as possible because I don't think this is a good time to go into all the finer details of this. I hope this is satisfactory or useful. Thank you so much.
Madam, there are some queries in the message chat.
Let me check. Hold on. Yes, I'm so sorry. First one is it the same as stable angina? Yes, this is same as stable angina. I forgot to describe that actually. Now we don't use that. Now we have this new term, chronic coronary syndrome, like acute coronary syndrome, that we have the opposite one, chronic coronary syndrome. It is similar to stable angina, but it is now the clinical spectrum has changed. That includes not the typical angina also, because previously we thought of typical angina as the patient, the stable angina as the patient who has typical angina plus obstructive coronary artery disease. Now because we take microvascular dysfunction or non-obstructive coronary artery disease also included in the this syndrome. So now this category is called chronic coronary syndrome. Prasadi, I hope I gave you the answer for that. Madam, what is the place for angiogram and stenting in stable angina? Actually, now the current evidence is that there is no prognostic benefit or the mortality benefit by doing invasive management of the chronic coronary syndrome. We go for invasive angiogram, PCI or CABG if patient is mainly symptomatic benefit. For symptomatic benefit, if patient does not respond to optimal medical therapy, then it is indicated. Or else, as I described, if we consider the patient is in high risk of future acute ischemic events, then there is place for angiogram and PCI or CABG. That depends on the patient's clinical symptoms, results of the stress test like exercise ECG, CMRI. The ischemia burden is assessed by the stress test, and that will help. If the ischemia burden is high, then you need to go for invasive testing, and then invasive testing followed by invasive management. So those are the main indications for angiogram and PCI. The other one. What is the place for beta blockers according to latest guidelines in heart failure? Is it only for heart failure with reduced ejection fraction? The evidence is mainly for heart failure with reduced ejection fraction. You can use it for mildly reduced ejection fraction also. But for heart failure with preserved ejection fraction, it has not shown any prognostic benefit with beta blockers. So the main evidence is for heart failure with reduced ejection fraction. Next question is, kindly explain isolated ST elevations in lead AVR and V1. I guess, is this in situation of chronic coronary syndrome? Usually, if the patient ST elevation in AVR is important in acute coronary syndromes. If the patient presents acutely with chest pain, ST elevation in AVR is important because it can indicate there is significant stenosis in left main or proximal LAD. Usually it is associated with ST depressions in chest leads, not solely with ST elevation in AVR. ST elevation in V1, it could be, if it is in acute presentation, could be due to, can be due to presentation like RV infarction also, but there are other associated ST elevations, and to my knowledge, I don't think there can be isolated ST elevation in V1. But in chronic situations or the stable patient, these changes are not described as significant changes. Is that okay, Sujit? Madam, do beta blockers have a mortality benefit with chronic coronary syndrome? It is actually mainly given for symptomatic benefit. It has mortality benefit in heart failure and in acute coronary syndrome. Beta blockers, I don't think in chronic coronary syndrome. Not in, to my knowledge, I'm not sure. Let me check that and I will give you the answer. Shall I give the correct answer with evidence to Sudesh? Is that okay?
Okay, madam.
Any other questions, Sudesh?
Yeah, chat box messages are, that's all. Madam, that common problem we encounter in people come with angina symptoms and exercise ECG done negative, but symptoms persisting. I mean, mainly that is basically the
even after giving best medical management, also symptoms are persisting.
Some patients may symptoms that is mainly short of breath mainly, madam. Short of
Mainly,
breath.
not typical
Mainly.
angina.
Not
Because if it
typical
is
angina.
say if the patient has typical angina despite medical treatment, then patient should go for invasive investigation and management, that is angiogram. And then because that
Right.
means ischemia burden is high. Say if the patient has only shortness of breath on exertion, exercise ECG is negative. You have treated for ischemic heart disease, suspecting chronic coronary syndrome, treatment started, but no response. Am I correct? Is that the
Yeah.
yeah? In that case, sorry. I'm sorry. You need to go for. You can go for other stress test, sophisticated stress test, because exercise ECG per se will not give the best information. So either you can go for stress MRI or other stress 2D echo, or else you, if facilities are available, can go for CT coronary angiogram, which will give us correct diagnosis. But unfortunately, we don't have the access to the CT, so we go for stress imaging test, because stress imaging tests are better than stress exercise ECG.
Right.
Actually, to be honest, ultimately we end up doing angiogram because of the we don't have all the facilities. Sometimes stress echo will not give the say patient is obese. Most of the time these patients are like this, the BMI is high, we can't have the proper images to do the stress echo in our country. In that case, since stress MRI, PET or CT scans are not available for us, then we go straight away go for angiogram. Actually, that is recommended in the guidelines. If the cardiologist suspects this could be angina, chronic coronary syndrome, then you can go. There is evidence space for angiogram straight away.
Right. There's one last question, like, madam, the possibility of getting slides here.
Yes, of course, can give. No, if they are helpful, yes, of course, I can give. I will email it to you.
Okay, madam. Yeah.
Okay.
Then
I will send it.
And madam, and this is a European Society.
Yes, this is 2024
guidelines.
ESC guidelines.
Guidelines, ESC guidelines.
I actually sort of simplified it, because I don't think we need to go into the finer details about evidence and everything. I just wanted to give an highlight about how to assess a patient and how to do the investigations, approach to a patient, and just briefly touch the management, because it will take hours to describe all of the things.
Yes, madam. In practical situation in Sri Lanka, so we are doing exercise CCG, exercise CCG negative.
Yes.
But there is a low risk of there, so we refer for CTCA.
Yes. Yeah.
CTCA, there's a problem. Some can't afford, and not available in some areas. So, madam,
and there are other problems with CT also. Say patient is above 70, then the calcifications can give false positive results. And if the CT is not performed correctly, this has happened previously. So it will again, I can either give false negative or false positive results. That again will be harmful. And if the patient is not in a position to undergo CT, like if there is uncontrolled heart rate and if the patient can't tolerate the CT, then those are the limitations of cardiac CT. You need to have correct expertise, and it should be available at an affordable cost.
That's right. That's right, madam. Right. Right. Thank you very much, madam. I think no other questions arises at the chat box.
No.
Yeah. Madam, thank you very much. Came here to come to this our continuous medical education program of General Practitioners College of Sri Lanka. And I know last periods how much busy were you.
Yes, I'm so sorry. I did not contact you most of the time, but this was in my mind. So
That's right, madam. So
even though I
we
did not
discussed
respond to your messages or emails, sorry.
months ago. We have planned. You have
Yeah.
give the correct plan. Actually, that's what this almost academic activities. So they are last months, right, madam? Right, and thank you very much, madam. Thank you everybody who joined with this today's CME program. And good night, everybody. Good night, madam.
Thank you, Desh. Thank you. Good night, and good night, everyone. And thank you for the college also. Okay.
Okay, thank you.
Thank you. Bye.